and welcome to this evening's webinar. I'm Karen Uzi. I'm Professor and Director for the Institute of Skin Integrity and Infection Prevention here at the University of Huddersfield. Thank you very much for attending this evening. Before we start the webinar, I would just like to give a brief overview of the School of Human and Health Sciences and the Institute. So School of Human and Health Sciences is the largest school within the university. We have 4 departments, and within that we have 7 research centres. And what we aim to do is play host to a dynamic and multidisciplinary research environment where we strive to support world-class research excellence that provides a significant and local and international impact. And tonight's session, we're going to look at wound care and how to manage wounds and how to try and close wounds, and also what's going on in the UK and the US in this environment. So tonight's session, I'm going to do an overview of the Institute, just so you know who we are and what we do. We're going to have an overview of the importance of wound healing, which will be presented by Dr. Leanne Atkin. We'll then go into the In Conversation With section of this webinar, which will be between Dr. Leanne Atkin and Dr. Bill Tettelbach. And just remember that we'd like you to add any questions you've got into the Q&A box. No questions are daft questions, so do feel free to ask it. And we'd like a really interactive session this evening. So the Institute of Skin Integrity and Infection Prevention is an international interprofessional institute which I direct. We have academics from across 4 schools within the university, practitioners from across West Yorkshire, but also globally as well. We've got international experts from Europe, America, Australia, and the UK. And we also include our service users as well, because obviously no research can be carried out if we don't understand what is the service user's perspective. And similarly, we need practitioners with us as well to ensure that the solutions are actually useful within clinical environments as well, rather than us in the university having an ideal approach. So our whole ethos for the Institute is for research and evidence to be brought to the bedside. And what do? Well, we do research, and we do blue sky research. That's research that's trying to look into the future. We also do research that has real relevance at the bedside, and that's why we've got this webinar tonight as well, to try and understand those real issues that are happening and to try and find solutions to them. We're going to take a range of product evaluations, and obviously as we're in a university, we're very keen on education, where we have a range of master's programs on tissue viability and leg ulcers, and also the very first business skills master's module that's aimed for those practitioners who work within tissue viability and leg ulceration services. We support our industry colleagues as well with their education, but also helping them evaluate and develop new products. And at the moment, we're looking at research that underpins antimicrobial resistance and the importance of implementing antimicrobial stewardship into clinical practice. We also do lots of research in wound infection, and we have members of our staff who are leading the International Wound Infection Institute. We're also researching skin tears at the moment, very under-researched area, and we really need to be looking at how to prevent and manage these wounds. And again, members of the Institute are members of the International Skin Tears Advisory Panel. And during and within the pandemic, because unfortunately we're not out of it at the moment, we're looking at PPE and skin damage, but particularly skin damage that's caused to clinicians. So we have a very wide range of research that we undertake, but we really do want it to make a difference to the end users, be it patients, their carers, their relatives, and staff as well. So tonight we have got Dr. Bill Tettelbach, and we're delighted Bill's able to join us. Bill's a certified wound specialist, and he's certified in undersea and hyperbaric medicine, infectious diseases, and internal medicine, and he has formal training in biomedical informatics. He's got a range of academic appointments, at both Duke University School of Medicine and the Western University of Health Sciences in the United States of America. And Bill's got extensive health policy experience, where he's dedicated most of his career to improve the lives of patients requiring the services of advanced wound and hyperbaric medicine. As I say, we're delighted that Bill's able to join us tonight and give us an insight into what's going on in the US. Our other speaker is Dr. Leanne Atkin. Leanne's a vascular nurse consultant at Mid Yorkshire NHS. She's also a lecturer practitioner based here within the University of Huddersfield. Leanne is also the national chair for the Legs Matters campaign. She's an invited member of the National Wound Care Strategy Programme, and she's a member of the All-Parliamentary Committee for Venous and Vascular Disease. So as you can see, we've got some excellent speakers, and we're going to have a very lively debate. So I'm going to hand over to Leanne now, and Leanne will be talking about wound healing and why we're not managing wounds. Leanne, I shall hand over to you now.
Hi all. Thank you very much, Karen, for that invitation. I'm hopeful that you can see my screen, and I'm hopeful you can see my presentation and hear me okay. If not, I'm sure somebody will let me know. Many thanks for the invite today. As Karen said, my name's Leanne. I'm a vascular nurse consultant within Mid Yorkshire NHS Trust, and I hope to be at home by the time to present this. But as you can see, I'm still within the hospital because at the end of the day, the patients have to come first. But what I'd like to talk to you about really is just take 10 minutes to set the scene about how currently across the UK and the globe that wound care currently could be called as being in crisis. And then I think that we're going to have quite a lively debate of how really America is doing this so much better than the UK and what lessons we can learn. So just to come back to it really, that if you think about wound care across the whole of the NHS, the UK and even the globe, wound care can be described as being in crisis. This is because a mixture of a few different factors. One of those is the growing population and the growing number of people over 65. The cost of this is becoming insurmountable. The numbers when we start talking about £28 billion is just unbelievable. And actually across the UK at the moment, between 1.25% of all of the beds are occupied by a patient with a wound of some description. And we know that this is a huge burden to our community nurses as well as our acute hospitals. And all of this is directly linked to Professor Uzi's passion in terms of antimicrobial resistance. When we think that 16% of all antibiotics prescriptions are attributed to wound care, we really have to think about why is the requirement so high and what does that mean in terms of future antimicrobial resistance. Within the UK, though, specifically, we have a huge problem that is growing year on year. There was an original study back in 2012-13 by Julian Guest that said that we were spending £5.3 billion on wound care within the UK. And actually, within only 5 years, this increased to 8.3 billion. And the amount of patients out there with chronic wounds increased from 43% to 49%. So if anything, we were getting things worse, even though we were dealing with more patients. And across the whole spend to the NHS, I think this graph really brings it home that actually we're spending as more money on wound care as what we are on managing obesity, and actually not too far below what we're spending on arthritis, heart disease, and even cancers. This is a major problem. And it's a major problem because when we start to look at healing rates, there are some stark issues. A simple venous leg ulcer is something that we know how to manage. We know this because of empirical research. We know that with good care, compression therapy, endothermal ablation of that venous disease, that you can get healing of 86% after only 12 to 16 weeks of therapy. So 86% after about 3 to 4 months. In reality, we're healing 47% after 12 months of care. And why is that? Well, there are a number of issues. all lead to this unwarranted and unwanted variation. The delays in terms of accurate diagnosis, the use of evidence-based treatment, the overuse of ineffective treatments, and we have a huge problem within the culture and the language of wound care across the UK. And that's really what we're trying to focus on and explore deeply tonight. And the reason is because every chronic wound that is out there currently started off as a small, simple wound. There is a question of, did we harm those patients by our apathy or the absence of evidence-based care? And that's the reason why that they are struggling with such a chronic wound now. And this is really important. We've all got used to exponential curves. But if you look at this, there is a window of opportunity within the first 6 months of a wound occurring. The chances of getting that wound to heal are the greatest in that first 6 months. And actually, if you've had that wound for more than 6 months, that curve starts to plateau. So the chance of healing 6 months onwards is only around 5 to 10% in the next 12 months. Now, we're not alone in saying this. NHS Improvement, NHS England has identified that we need to do better. And they've set up a programme called the National Wound Care Strategy that I was delighted to be joint chair of for the lower limb stream a few years ago. And the quest is to actually eliminate that unwarranted variation in care as a way to reduce spend, reduce the burden on the NHS, but most importantly, reduce patient suffering. So that will help get rid of those problems that we talked about in terms of lack of identification of diagnosis, lack of evidence-based treatments. They should be embedded now because of the work that the National Wound Care Strategy is doing. I think the culture and the language across the UK is still causing a huge hindrance. I just want to talk to you a little bit about the history of where we've been. So it's important to remember that everything evolves. Wound therapies or wound dresses have evolved greatly. We started off in the 1980s with things just like gauze or betadine. In the 1990s, we developed advanced wound dressings such as foam dressings, hydrocolloid dressings. And actually more recently, over the last decade, we've actually started to produce dressings that actually promote wound healing. I think one of the issues within the UK currently is that we still call advanced wound dressings if it's a foam dressing or a hydrocolloid dressing. Is that really advanced, something that was created in the 1990s? Each and every one of us just needs to look at his iPhone to think that how technology has evolved since the bricks we used to carry around in the 1990s. And one of those innovations is EpiFix. EpiFix is a decellularized human amniotic tissue graft. And actually, this comes from the placental layer of a mother in America. Very, very amazing scientific stuff. But what that provides when you place it onto a wound is the scaffold and all of the growth factors that needed, all of the enzymes that needed to be able to kickstart that wound healing. And EpiFix aims to enhance wound healing, modulate the inflammation that we know is the major cause for chronic wounds that become static, and actually reduce the formation of scar. EpiFix has got a large evidence base. There has been multiple trials that's out there, all of them proving efficacy and safety. EpiFix is just one of the solutions out there, and we don't want this session to be about EpiFix alone. But I just wanted to share with you the case study that I've done with EpiFix. There's a number of complexities that makes a wound hard to heal. There are issues with healthcare professionals and how they are educated and the care they deliver. There are issues with resource in terms of where the patient can go, who can see them, what is their access to specialist services. There are patient-related factors in terms of comorbidities and complexities of underlying etiology. But there are specific wound-related factors, and this really is where EpiFix sits, to say that actually, if everything else is working well, and the only thing is the wound is not advancing, then actually we need to be looking at real advanced wound therapies, something from at least the last decade. When you think of a patient with a wound, if I ask you to imagine in your mind's eye who owns this leg of these pictures that you can see, I think many of you would think of an elderly lady. Imagine having a wound that morphs differently, but is there over a matter of 3 years going nowhere. Imagine the impact of that. That leg is owned by that lovely patient sat in that chair by the name of Tracy. She was 36 years old with 2 young children when she developed her leg ulcer that didn't heal for many, many years. And I just want to share with you her words of the impact of what it's like to live with a wound. She told me she's upset about the life she could have had, the career she should have had, and the person she should have been. She always thought that she would achieve something in life and be somebody in life, but she feels that she's had that opportunity stolen away. She hates feeling self-conscious, disabled, unattractive. She hates the way the leg ulcer has taken away her self-confidence. And that is the reason why we need to get better. Because Tracy suffered with a non-healing wound for many, many years. We started her on EpiFix, providing that scaffold, that nutrients, those enzymes, those growth factors direct to the wound. And the outcome we saw was phenomenal. We were able to get this wound to heal within a matter of weeks. When we think about how long it took before, of many years, she went from week 0 to week 19 of having a closed wound. And why was that? Because she had access to proper advanced treatments. We know that dressings cost a lot of money, but actually it's a small proportion of the overall cost to the NHS. We need to be thinking not really of saving money on the product we put on the patient, that is the smallish fish in the pond. We need to be thinking of the larger costs. The larger costs come from the GP appointments, the pharmacy appointments, the practice nurse, the community nurse's involvement in that patient. And the quicker we get these patients to heal, the cheaper it is for the NHS. But non-healing costs so much more. It costs the patient their quality of life, their ability to work. They have to pay for each prescription. They have to take the time out of their diaries to be able to achieve a dressing change. There's also links to clinicians' time, antibiotic spend, analgesic spend, and the whole service capacity. So we have to get better at managing these millions of patients out there that's currently got a wound. And for that, I think it's time to change. I think it's time to change the language we use within wound care, and that's what me and Bill are now going to explore. I think we really need to be only using the words advanced wound products when they truly are advanced, when they are fit for purpose, when they actually alter the wound bed to promote the physical change that's needed. We need to be thinking not about managing wounds. We need to be questioning closure of wounds, tracking healing targets, questioning when healing doesn't occur. We need to change the culture within the NHS. Non-healing is not normal. It shouldn't be accepted. We should be escalating to the right specialist clinic sooner in a patient's pathway, and we need access to the right products at the right time to facilitate this healing quest. I hope that's provided a quick insight in terms of what are the challenges faced at the moment within the NHS, and I welcome our ongoing debate. Thank you.
Leanne, thank you very much. Fascinating presentation as usual, and it's really nice to hear the patient's voice as well in the middle of it. But very sad that we're having to talk about language when it's something that you just think, well, language is around. So that's really what I think the conversation should be about, something that is so basic, if you like, but we struggle with it. And I laughed when you were talking about these old dressings, because I'm still in the 1980s, I think, and Somebody's stolen a lot of years somewhere along the line. But I'd like to ask you and Bill as well that I might be stuck in the 80s, but other people aren't stuck in the 80s, hopefully, especially our clinical practitioners. So why do you think that we're still trying to manage wounds rather than close wounds? And I'll come to you first, Leanne, and then I'll come to Bill for the US perspective.
I think this is where the US is far superior to us. And I think that their payment by results, in a way, makes sure that you're actually focused towards healing. And I think, as my presentation described, we have this apathy within the culture of the medical workforce that, oh, it's a wound. Oh, we'll manage that wound well. But we never actually look further than that.
Bill, do you want to come in with that one?
Yeah, so it's interesting. It's a very interesting topic, and the fact that one may be superior than the other in the way of systems. I think it's really that if you look at both the U.S. and the U.K. or the NHS and say what's driven by Medicare here in the U.S., and we have more of a fee for service versus it's a population health model. I think really the happy medium is is going to be, where there's a little bit of both, driving it. But the other thing is there's pros and cons on each side. I think that drives some of the management issues versus the treatment goals. We do not have nearly in the US the per capita outreach of community nurses. And, so this allows for, I think, offloading of clinics, but there also is the problem with education and getting those individuals who are out in the front line, being able to recognize that stasis or, keeping something just the way it is not necessarily the best option. That's where you got to understand when to refer, get them into the specialists. Where in the US, because of the fee for service, we have these far more acute wound care clinics, that kind of outnumber. And unfortunately, some are driven just by profit instead of just for the patient. And that's where you need to, sort of quell that and not have that. We're really here to do the best for the patient. And if we had more, I think, outpatient reach, referring in and being able to manage that, where in the NHS, you had more acute clinics or hospital affiliated clinic with well-trained folks, you would see your healing rates just go up significantly. Here in the US, we have, say for our DFUs, we have healing rates anywhere from 50 to 60% using standard of care, which is really alginates, foam dressings, where, if you were seeing, say, healing rates in the 40s, that you could almost go up 10% just by simple referrals into those who are more specialized. So I think there's the answer line within both systems that need to sort of meet in the middle. That's just my opinion.
And I completely agree with that, Bill, because I think what we haven't got within the UK is that specialist wound. You have specialist wound doctors. You are a specialist wound doctor. Within the UK, nobody owns wounds. Plastic surgeons sometimes, vascular surgeons other times, diabetologists other times, but our tissue viability teams aren't actually aligned with any specialism within medicine. I also think that, in a way, I'm not too sure whether industry has helped us with this, because obviously there is money to be made by managing wounds. If you don't heal them, you'll need the product longer. And I know that I work alongside many respectful industry partners who have a very ethical approach to that. But I don't think that that's actually throughout the whole of the UK in terms of the wound care industry.
Leanne, can I just come in there? And this links to the question that somebody's asked as well. We're talking a lot about advanced wound dressings here because they definitely have a role to play. And that, as Bill says, it tends to be medical-led in the US, we're very nurse-led in the UK. But how do we ensure that the dressings are the last thing really we should be thinking of? It's nutritional status, pain management, looking at the comorbidities. How do we change that language and to make sure people do look at the patient as a whole and everything else that's going on?
Oh, that has to be a fundamental starting block. Me and Bill wrote a paper probably 2 years ago now called Timers, and we very much called it out Do not spend money on regeneration products such as EpiFix until you've got the fundamentals right. You're wasting your time. You need to ensure that we have that holistic assessment, that their complexities are managed, that you're aware of the underlying etiology and that is treated. And then you've got a wound bed that's adequately debrided, the infection and the bioburden's controlled, the moisture levels are good, and you have healthy looking wound edges. And it's only at that time should you start about getting that regeneration. You know, along all of that, Karen, there is huge movement we could make. Debridement within the UK means what to an average nurse? It means putting on a piece of hydrogel or something like that. Debridement in the UK, in the US is very, very different. It's mechanical debridement, often with a curette there and then. You know, we have a lot to learn.
Bill, just to ask you that, because we've said that in the US it's very much physician-led. So how do you get the physicians to think about nutrition and debridement as well as, and think about the dressing last?
So the thing is, you know, as we're all hinting on, you know, wound care is not owned necessarily by one individual. It's a multi-specialty specialty. So everyone has to be networked in to be working together. For limb salvage, you know, my background is infectious diseases, underseeing hyperbaric medicine. You know, to be transparent, I do work in industry and I help develop regenerative products. But again, these aren't frontline products. I have to have my vascular surgeon and my orthopedic surgeon on board to not necessarily just go ahead and amputate everything without letting us have a look at it or bring us into the loop and give our opinion, and vice versa. They may run into where they've exhausted all their steps within the reconstructive ladder, say a plastic surgeon, where we may have some the time and the wherewithal to sort of work with these wounds to get them to heal, you know, instead of just a quick fix with a going to the OR. So, you know, nutrition is a big part of this. Even in the US, I think we're even more hindered because we can't necessarily afford to embed, say, a dietary or a dietitian in our clinics. We have to sort of bring them in for consultations. You know, it's that whole, you know, fee for service model where you got to make it work. And how, you know, versus where in the NHS, you have people who are hired, they're employed. If they need to be, you know, utilized here, well, then they're the patient is set up and they see them and there's no questions asked. The best wound care clinics are going to be those that have all these touches literally within the same hallway or very close to each other, or you have those docs, like you said, vascular folks rotating through once a week where you're lining those patients up. You have your nurses who are working, who aligned with everyone. We have plenty of advanced practice providers who work in the wound care area, but again, they get very little training before they show up at a wound clinic. We would train our patients up 6 months. You know, these advanced practice clinicians would get 6 months of training, you know, not necessarily having to watch for 6 months. It would be several months of weeks of watching, then, you know, see one, do one, and then kind of on their own with more lighter oversight. But you know, there's a lot of education and training that has to be done to allow all of this to happen. And then just getting folks on board, your other docs, to actually think about us instead of just going straight to the OR for a simple solution, which is, again, the cost post amputation goes way out the roof versus some of the limb salvage in appropriate situations.
And I think that, you know, many of our wound care is delivered in community. And, you know, many of our community nurses are fantastic at doing this. And many of them recognise that a wound isn't healing. But they've got very little options of where to go then. You know, they may have links to a local tissue viability nurse, but there could be a time lapse of that referral of when to be seen. You know, it's very difficult if you've got a non-healing wound. If you're a diabetic foot patient, that's great because you can go to the diabetic foot service. But if you've got a non-healing wound of any other etiology, where does that go? Where does that community nurse get that support? And I think within the UK that support is really lacking.
So this is go ahead.
I'm just thinking that you both talk about multidisciplinary team working here as well. but what other barriers have we got? Because we know the theory and the ideal is that we'll all work together, we'll all be in a clinic together, and we'll all discuss things at the same time. But unfortunately, some patients as well who will sit and listen to you both and smile in all the appropriate places, and then they go home, take the compression off or take the dressing off, and then pretend that they've never touched it before. So then your wound's not going to heal. How do we overcome those sorts of barriers?
Leanne, I'll let you go first.
Yeah, I think, Karen, that we are far too quick to blame the patient. Far too quick. The patient's non-compliant. The patient won't do what we've told them to. Has actually somebody sat down and educated that patient of the reasons for that compression, of what they can do, of other options of alleviating that pain if that's the reason why they were removing that compression? I've never met one patient who wants a chronic wound. They all want it to heal. It's just about meeting a clinician that they believe is good, that they have confidence with, and they can build a therapeutic relationship with. And I think that we really need to stop blaming the patient. And we really need to turn this round. Is our services fit for practice? Is what we deliver good enough? Because actually, if I were a patient and it's taken you 8 months to get some compression therapy on me, and I see very little improvement because I've missed my window of opportunity, and I have different nurses coming in every time with different ideas, and all of them want to try a different wound dressing. Well, I'm sorry, but forgive me if I lose confidence in you and I decide not to do that. It's all about getting that therapeutic relationship built within that patient the earliest possible time.
So Leanne, sorry, Bill, I will let you get in a minute, but it's just there are some patients, in fairness, that you can go, you'll put the wound dressings on, and then they sort of use the wound as a bit of a sideshow when the relatives come and they say, come and have a look at this, isn't it brilliant? But that beside the point, there's very few and far between. Why do you both think that clinicians don't always refer on to specialists at the earliest possible time and wait until the wound is either the patient's not eating or the patient's not drinking or the wound has deteriorated? Why don't we refer in a timely manner?
Well, one of the things I think is you sort of just backstepping that, with the, people who are maybe not, taking in the directions and really being, the compliant to the treatment, course put on hand. Some of this is set up for exactly what you're talking about. So if you're with, say, another primary care doc, or you have a community nurse and you've been going 6 months doing the same thing or very little variation, you kind of become a non-believer, or you kind of, you become sort of, this is the way the rest of my life is going to be. So when they show up or finally get referred, trying to break through that barrier, it can be difficult. And a lot of times that conversation is like, look, this is day one. This is the first day of someone actually trying to treat this wound. You have to convince them that it's not what it was, he or she. And so the data, so being the principal medical officer here at MiMedx, I've had the opportunity, we're actually publishing a Medicare study looking at advanced therapies, particularly, say placental derived, but there's all host of advanced therapies, even negative pressure is an advanced therapy. But the thing is that the data shows that docs who are treating with standard of care will wait up on an average to almost 70 days before even initiating a particular type of advanced treatment. So that's a long time on average. So it's really, I think it's like we talked about, it's education, it's getting to the nurse conferences, talking about the availability, what is being offered beyond what they're doing. So that's part of the solution, is bringing everyone into the fold and knowing what's there, even telehealth. Someone sending a picture to a viability nurse in the clinic saying, hey, I'm having problems with this. And it's an unidentified, they can just say, look at this wound, and you can go, oh, they need to come in, or let me call you later. I think there's something we could do if we talk a little more. But those are simple steps that can turn everything around.
And I believe that that non-believer status also happens within nursing. I think that they believe that this wound will never heal, that this is how it's got to be. We'll be mopping up that exudate forever. And I think that we really need to shake those non-believers to say this isn't how it should be. You know, we should be questing healing. If healing is not occurring, we should be seeking further help. And I'm the chair of the Legs Matters campaign, and we have many emails every single week, desperate families and desperate patients trying to seek that healing, but somehow just being patted on the head to say, oh dear, with nothing else, of no other hope. And we really need to challenge that.
Leanne, why do you think then non-healing is sort of acceptable in tissue viability? We wouldn't accept somebody having a leaky heart valve and saying, you'll be all right, just hang on another 18 months. So why do you think it's so different in wound care?
I think it goes down to the culture, and I think this is one of the reasons why I was so excited to be part of this today. I think it's multifaceted. It's that lack of specialism, it's that lack of drive, it's that lack of where do they ask, who do they. If you are a tissue viability nurse, who do you go to get your education? How do you learn more? You know, within a medical structure, you have juniors, registrars, consultants, senior consultants. Within a tissue viability nurse, you are the one. There is nothing round you. And how many times have I sat in clinic with a patient that is a challenge to get to heal, where I need a firm of people to come in to give me advice. Microbiology, plastics, what's the possibilities? Let's do some arterial studies to make sure that everything's done. Let's operate on those veins. And many of our tissue viability nurses are working with one lone specialist. And I think what Bill and I are both echoing is actually those most complex of patients with the most complex of wounds need that multidisciplinary approach. And within the UK at the moment, that's not truly provided. And I think that that needs to be the quest.
So there's also, I was sort of looking on the Q&As, and there's a number of questions about diet and the importance, and is advanced therapy more important? So the question is, and I'll reiterate what Leanne said, that you have to get the foundation of the building blocks in place. And so, if you're overweight and diabetic, diet in itself, how would it impact that? Well, just, you don't have to lose, an enormous amount of weight. You just have to lose 10% of your body weight to impact your diabetes and improve all your outcomes. And getting your sugars under control doesn't mean so if your sugars are out of control as a diabetic, it doesn't mean that you cannot get a wound to heal, but it does mean that your immune system is not effective. It can't fight infection as well as it should be. So getting the A1C down will help protect you and keep these wounds from getting reinfected, or because once you get an infection, the likelihood of having once you get a chronic diabetic wound infected, your likelihood of getting an amputation goes up 155 times. It's an incredible number. So that's why it's so important to get these wounds closed, because just treating the infection doesn't take that risk away. And you also have to understand that once you have a lower extremity amputation, like a major amputation, like a below the knee amputation in a diabetic, your 5-year mortality rate goes up to 56% or more. So that's, these are things you want to avoid, and you can, that's why we're here, to improve quality of life, to maintain quality of life, to offload the healthcare system by, getting you healed.
And like Bill says, that, we are not saying that this is the panacea and this is what all needs. We need to start on those foundations, but we just need to bring home that, in terms of diabetic foot wound, your outcomes are worse with the diabetic foot ulcer than what they are of having many cancers. So we just really need to bring home that we need the skilled workforce to deliver this. But, I really have to question that, get the fundamentals right, get the foundations right. But when we're talking about actual wound management, we need to be talking about basic wound management and advanced wound management. And advanced wound management, we shouldn't be classing as applying some form of foam in today's era.
Yeah. So one thing also to put on the Julian Guest data, there was a recent paper out that was talking about, say, placental-derived tissues, and the statistics are using these Markov models. Basically, showed if you spent, say, an extra 3,200 pounds on this type of advanced tissue product, compared to methods used as currently intact, standard of care, alginate, say, an alginate dressing and foam, you would basically, have the same treatment costs, but your outcomes would improve in such a way that you would offload, you would reduce the number of ED visits, you would reduce the number of major amputations, you would reduce the number of complicating infections. So this in itself saves the healthcare system money and the patient time and grief, but that frees up more money to do more preventive, work for these chronic wounds to avoid them. So, that's the point where advanced therapies really can impact every level of healthcare, from the patient to the large trusts.
I'm just listening, and we're talking a lot about language, obviously, and the two of you using language quite interchangeably here. So talk about chronic wounds, hard to heal wounds, advanced therapies, basic, fundamental. So if we're using all these terms like this, how do we ensure that clinical staff who maybe haven't had time to read all the research and evidence, haven't had opportunities maybe to get lots of education, how do we get language across to them that we use properly? Because some people will think a foam dressing is advanced because it's not a gauze dressing. So how do we get that over, and how do we change language?
Well, we've been spoon-fed for many years that advanced wound products are things like foam dressings. And we just need to all be saying, don't be daft. Nothing from the 1980s is advanced anymore. We've moved on from them. But you are exactly right, Karen. Even at our level, the words we use are interchangeable. What that means, chronic or hard to heal, do they mean the same thing or different thing? And actually, that this needs to be led from academia through industry down to the health service providers, that we do get one language. I hate the word chronic. It just means time. That's all it means. And in a way, it means we're giving up on you. You've got a chronic wound, so we expect it to be there forever. We really need to be thinking of patients, of their ability to heal. If their ability to heal is relatively good, then we can manage them with traditional wound dressings. That's fine. But actually, if you're identified as a hard to heal patient in potential, we should be watching you very closely. As soon as you hit that time point of no non-healing at 12 weeks, we should be referring you on to receive more advanced therapies.
So the thing about the gauze also that's interesting, there was the Agency for Healthcare and Quality Research here. It's a CMS, entity that gets tasked with reviewing and putting out technical briefs. The last technical brief they did about skin substitutes, they noted in the document that they did not even analyze studies that used wet to dry gauze as a control because it was so outdated. So that technical brief in itself standardized alginates and foam as now standard dressings, not advanced dressings. So.
And we're doing the same across the UK, because NICE believes that topical negative pressure is an advanced wound management. And of course it is. How that stimulates the cellular matrix of the wound is phenomenal. We really need to be thinking about how do we change the cellular structure of the wound with our therapies, not simply of putting something on top of them to manage them.
And that's where we struggle in the US and we struggle in the UK. We don't have a dedicated educational track that everyone has to go through to standardize this. And that's something we've been working on in the background to try to get in the US. And I'm sure that's a desire from all the academia and practitioners that would love to see this happen in the UK system or NHS system.
There's also, and we talked about stuff about the future of wound care as well here. We're sort of mixing in with fundamental, the 80s. Leanne, I don't actually think it is that long ago, the 80s. You're trying to make me feel very old. But at the university, Leanne knows about this, that we're exploring looking at 3D personalised dressings at the moment, with implanted cellular material. And it's going well, it's looking good in the labs. Do you think this could be part of the future? And that's to both of you really, that we could have these bespoke 3D dressings for patients.
Well, so for I mean, like when I started my training and when I was doing bioinformatics, customized, medical care has been the language for almost 20 years now. And we're getting closer and closer. This is basically, they've done this in oncology, where they basically can do a genotype and a phenotype of your cancer, find out what chemotherapy drugs will actually be resistant to or actually be more effective to. So this is personalized, tailored medicine, where before it used to be that you came in, you got a protocol, didn't matter. If you had small cell lung cancer, you got this protocol. But now they can put you through a gene bank and find out what treatment grouping is going to be best for you. That's, I think, with 3D printing, being able to actually understand what we talked about on a cellular level, understand what is missing in receptor expression in these chronic or hard to heal wounds, what is overexpressed, what needs to be put into the dressing to rebalance the healing cascade. That's the future. And the 3D printing is part of that, because you can put anything into these, eventually. Leanne?
Yeah, that individualized, at the moment within the UK, we'll put a debrider on, or we'll put an MMP modulator on. A wound just doesn't require 100% of one therapy. The simple things of getting a dressing that you could have that bit doing debridement, that can be mopping MMPs. You've got a bit of biofilm on, you've got a bit of cytokine depression here. All of that must be, every patient is individualized, every wound is individualized, every need of that patient is different. I think there's a huge challenge though, Karen, of how do you go from that big, massive lab that we have within the university to produce one single little dressing? How do you go from that to delivering that within everyday NHS care? And I think that is a challenge. But at the same time, I know that there's more technology in my phone these days, and the world went up on the first ever shuttle to the moon. So, we have to reach for the sky with these things. And I think that's one of the things of changing the language now, that questing for healing, stop the apathy of non-healing, and talking about advanced therapies that are truly advanced. That will only help to actually embed that we need to carry on with the science, the evidence behind this. Gene therapy is going to be the thing that hopefully is going to revolutionize illness going forward. And I think it's perfectly suited for wound care.
And so this is also the transition, in the sense that we in wound care, a lot of times we talk about having a quiver of arrows, and we have to, like, every couple of weeks change our dressing, because not every patient responds to the same dressing every time. So it's like, all right, this isn't working. Let's go from the silver alginate to a hydrofera type, with methylene blue in it, or ginseng violet. I mean, it's eventually you find something that works and you stick with it, but it's not the same for every patient. It makes it very difficult.
And I think that really links to bedside diagnostics, that, how do you diagnose a wound infection? Well, get 10 clinicians and they'll give you 10, you'll get 5 positives, they've got cellulitis, 5 negatives. If we're able to develop bedside testing that's able to check what is it infected or not, what is that bacterial burden there and then, or is it just biofilm or localized infection? It's the same as developing dressings that actually feed back, what is the temperature of the wound bed, what's the pH, what's the MMP level doing over the wear time? All of this is possible within the science that comes from the university. The question is how do you actually bring that to life to everyday clinical practice?
So I'm listening. I want to pick up some of the questions that people have been asking as well. But in a nutshell, I think what you both said is that get the fundamentals right, first of all. So diet, nutrition, mobility, etc. And debridement, obviously, and then think about which wound dressing do I need, what am I trying to do for the wound as well, and then measure the outcomes. and also that we should be working in a multidisciplinary environment, and that some patients will be non-concordant. They always will be, maybe patients with dementia, etc. And that we need to have education being delivered to everybody so that people have the opportunity to learn. But somebody has asked, and I think it starts off from Leanne from the beginning of your session, where she talks about wound care in crisis. And they've said, are we in the official crisis now?
I would say yes, and I would say yes for the amount of spend that we have in wound care. I would say yes, that how dare we have 47% healing rates for simple venous leg ulcer at 12 months. I would say yes, because actually if you are a community practitioner out there, I bet you can't even tell me your healing rates. If we're not monitoring, if we're not measuring, how can we tell if we're doing good care or bad care? You know, we need to get better at measuring. We need to get better at outcome data reporting, and we need to get better at benchmarking. You know, we should have a national map of how long across different counties does it take to heal an average leg ulcer, an average diabetic foot. That atlas of variation will help to pinpoint where we need more investment, more education. Maybe we need to change the language and culture more within specific areas.
Bill, do you want to add anything in there from the US perspective?
Well, I mean, it's, you know, when it comes, you know, the language I think we've used is what we try to express what is needed. You know, one of the things, you know, I think I try to, when you're talking to a group and you're just trying to put it down in simple terms, everything that you stated kind of leads up to this. First steps are wound bed preparation. Now that again is everything you talked about mechanically with the wound bed, but you know, with the body, social issues, you know, if they, you know, someone to help change the dressing, if they're able to make meals, you know, getting to the clinic itself, you know, everything, you know, if you can get all those aligned with diabetic ulcers, more than, you know, 50% of those patients or more are going to go on to a trajectory of healing. It's the other 50 to 40% that will not go further, and it's going to need a more advanced therapy. And that's where the referral network needs to be put in place. That's where your multi-specialty network gets engaged, even during or before or after. And then that's where it's sort of stepping up. So, you know, you're stepping up to something more than what you were doing before to get these folks closed. So, you know, we struggle with the same things here in the US. You know, research, there's hardly any research, you know, in the sense that it's funded by the government. You know, unfortunately, a lot of this comes out of industry, and then you have to sort of gauge this on the level of, you know, is it biased or not? Is it, is it something we really need, or is this a future product that's not even available yet? So just like the basic data that Leanne was talking about needs to be analyzed and revealed to the public, you know, practitioners. And with that kind of knowledge, there's power, and there'll be much better, you know, outcomes.
And I think there's an issue as well that we're quite reactive to what we do. We've talked a lot tonight about wound dressings and education and how much it costs to do research. But I think we really need to take a step back sometimes and talk about prevention. That if you invest in, like you say, educating patients, invest in more staff as well, and invest in pressure redistributing devices, offloading devices, we can hopefully prevent the wounds happening anyway. And it's a different conversation to have, but it's very hard to measure outcomes from prevention because we don't know how many we've prevented. Whereas if we've managed to have measurements for reduction of infection or reduction of diabetic foot disease, then that's easy. But how do we say we've prevented 20% of wounds becoming infected? And from that, sorry, Bill.
No, I was gonna add, you know, the prevention, we underestimate all the time the burden of, you know, what's happening in the community. So we're not putting as much, I think, effort into the prevention side. So when I used to be an executive director with Intermountain Healthcare, it's kind of a large, say like a Kaiser type, you know, system here. we had, say, like 4 clinics when I first showed up. And I remember putting these proposals together to expand, a new clinic. And it was a 5-year proposal, what we would need it in 5 years. We filled those clinics. The minute we opened up a clinic, we were understaffed in 5 months, overbooked in 5 months. We did that for 3 clinics running, where we had to put out a whole 5-year projection. Every time we built a clinic, it was overbooked within 5 months. And we had to staff up. So this is where we're not even touching on the ability to really treat the acuteness, let alone we're underestimating the need for the prevention. It's needed across on every level.
So I think, oh God, Leanne, sorry.
And I think that lack of resourcing really is the heart of why we are in a bit of an issue within the NHS.
Crisis.
Absolutely, because our community nurses, every one of them, do a fantastic job. But unfortunately, because of the pressure that's on them, they end up doing a transitional dressing change. Let's change it quickly, rather than stopping and thinking what more that they can do. And actually, if you can give them enough time, they would be identifying non-healing wounds, at-risk patients. They would be wanting to escalate further. We just need to ensure that it is appropriately resourced across the board. And prevention is not delivered currently by the NHS. I think COVID has really affected the prevention issues. And I do worry what's coming, if you like, within 4 or 5 years of us taking the eye off that prevention ball.
I'm just going to answer a couple of questions in one rather than asking Bill and Leanne about this. So, are podiatrists dealing with leg wounds? Some of them are, some of them aren't. Leanne and I discuss this a lot of work because we work with our podiatry colleagues, and we say that you deal with the lower limb. So there's no reason why you can't also look at the prevention, management and treatment of leg wounds as well. So anything really from the groin down. So I think there is a huge place for podiatrists here. Great expertise, great specialism. And sadly, sometimes overlooked, I think, because people think you're just from the ankle below. So yes, definitely get dealing with leg wounds and do CPD in wound care and leg ulcer management. There's also a question about, is there a place for a national wound care pathway rather than trust-based pathways, which could be in a difference between hospital and home? And because Leanne is nodding away like our loving nodding dog, I'm going to hand over to Leanne for this one.
Yes, and that's what I would like to see the future of wound care look like. I would like that, if you like, that escalation pyramid with specialised centres running down the centre of the UK. So therefore, there is a referral pathway for these patients who are failing to heal. That's what we should be calling for, that nationalised. We've got nationalised clinical guidelines of how to deal with them, but we need national structure to actually facilitate that now. And that, to me, is the absolute key.
So we're nearly out of time, but somebody's just asked, how long do you think COVID will affect healthcare? And I think it's going to affect it for a long time. There'll be some positive.
Forever.
I think very positive about self-management and self-supported care. And I do want to end on that positive note, really, because sometimes we say COVID and everybody starts thinking, oh my word, this is dreadful. But we've got to look at some of the good bits that have inadvertently come out. So Leanne and Bill, I would like to thank you immensely for spending the evening here with us all. I hope I've got through most of the questions for the participants. I've tried to integrate them into the questions and answers as well. I'd also like to say that, yes, pharmacists can train in wound healing as well. There's no reason why not. From the COVID perspective, pharmacy have actually been really the first point of contact. So yes, there's a best practice document that's just been published, which is available free to download from the Wounds UK, Wounds International website. So please feel free to have a look at that. So once again, thank you both for joining me here. Thank you to all the participants, and I hope you've enjoyed it. I'd be really grateful if you could fill in an evaluation form that we'll be able to send to you, just to let us know what you've liked, and also we can make any changes if needed. If you want to learn more about the events that we host both through the university and the Institute for Skin Integrity and Infection Prevention, please join our mailing list, and you can email Leisure Yang or follow us on Twitter at ResearchIsAce. And you'll be delighted to know that I will be back in the hot seat on the 27th of July for our next In Conversation With, and that'll be with Dr. Sarah Jarvis, OBE. And Sarah and I are going to talk about what has been the success of COVID. So I hope you can join us for that as well. So that'll be the 27th of July at 5 o'clock. Once again, thank you all very much for listening and attending. Thank you for all the questions. They've been absolutely brilliant. Apologies if I didn't get to answer some, but I did try and integrate most of them in. So have a lovely evening. Thank you and good night.